Welcome, friends, to this another session at Gujarat at the 26th AIDS conference, the World AIDS Conference, which is the 26th International AIDS Conference or AIDS 2026, which is happening in Rio de Janeiro in Brazil. We are here in the Global Village Networking Zone at the session space of Gujarat AIDS Awareness and Prevention Unit and partners, and GAP uh, and we welcome you on behalf of that. And this is the session on the theme of 54 months are left to end TB and AIDS. Are we doing our best to prevent, find, and treat all TB among people living with HIV? So before we go into the before we listen to our speakers, I think I would like to say very important uh, perhaps a very important reflection on the latest data on UNAIDS, which was just released on 2 days ago on 27 July 2026. So there are almost like 1.2 million people who contracted were diagnosed with new HIV infection in 2025. 570,000 people died of AIDS-related illnesses. And we know that TB continues to be the biggest cause of death for people living with HIV. When we say TB is preventable and TB is curable, it is not preventable for 1.2 million people living with HIV. It is not preventable for so many people who died of TB, who were living with HIV because thanks to ARTs. So because of ARTs, they were living, but they died of a preventable opportunistic infection like tuberculosis. So I think we can do a way more better in saving lives from TB, not only among people living with HIV, but also otherwise, because no one should get infected with TB if we have good infection prevention and control, if we have TB preventive therapy in provided to all those with latent TB, and I could be one of them. Also, because I live in India and almost half of the population could have latent TB. Also, we need to do better on tobacco control, alcohol, NCDs, diabetes, for example, or HIV prevention, or ensuring that every person with HIV is U equals U. So there is no excuse. There are only 54 months left to end TB and AIDS. We must deliver on these targets because it is doable. We can do better. Without any further ado, I would like to thank my colleague, Mr. Pankaj Patel, who is right there in Rio de Janeiro. He is the project director at Gujarat AIDS Prevention Awareness and Prevention Unit of ISRCDE in Gujarat, India. And so thanks a lot, Pankaj. So let us now, first of all, listen to Dr. Po-Lin Chan. Dr. Po-Lin Chan, friends, is a noted person, many of you will be knowing her. She heads the World Health Organization's Southeast Asia Regional Office she's the unit head for hepatitis, HIV, sexually transmitted infections, for elimination of mother-to-child transmission of HIV, as well as tuberculosis. So this is who could have been a better person to set the stage. So over to you, Dr. Po-Lin Chan, for your opening keynote address.
Hey everyone, we have a good time. IES 2026 in Rio. Thank you, and I would like to thank the organizers, CNS and partners for inviting me to present on HIV, hepatitis, STIs, and TB overall, and an overview in the WHO Southeast Asia region. We are 54 months left to the SDGs 2030, and this is about how we will connect the dots and moving forward. So a bit about the WHO Southeast Asia Regional Burden, Hepatitis, HIV, STIs, and TB. We are a region of almost 2 billion people with 10 countries. And in the WHO SEAR region, we are around 14% of the global burden of people living with HIV, people living with hepatitis B and hepatitis C. There is 8% of the global burden of people living with HIV, including children living with HIV. And the region has 16%, around 16 million new infections of the 4 curable STIs, consisting of chlamydia, gonorrhea, trichomoniasis, and syphilis. As you can see, the epidemic impact consists of new infections and death, but also infections among very special population groups, including pregnant women and children. We have still 8,000 cases of congenital syphilis, still 3.5 years from the SDGs. Globally, the Southeast Asia region, including India, has very high substantial burden of TB cases. The region is around 40% of the TB cases and global TB deaths. Almost half of all TB households have catastrophic expenses. But the good thing is that the region fares well in terms of TB case notification and in treatment success. So in the WHO Southeast Asia region, we have and are guided by the Integrated Regional Action Plan for Hepatitis, HIV, and STIs. So in the last year or so, we had a midterm review that showed that there is major policy shifts and political commitment, including many new or updated national strategic plans done in the last several years. And however, there is still challenges in financing these plans and getting refinements of program implementation. There is proof that triple elimination is achievable in the region because we have now 3 countries that have either dual or triple elimination. And integrated multi-disease elimination is feasible with practical service approaches. So over here, our experience of triple elimination of HIV, syphilis, and hepatitis B is that countries can achieve it, but we in this region will need large countries which have large populations to champion and continue to accelerate with subnational approaches. So last year in October, we celebrated Maldives being the first country globally who have achieved triple elimination of HIV, syphilis, and hepatitis B. And Thailand and Sri Lanka are currently working towards the 3rd elimination based on their experience of having achieved dual EMTCT of HIV and syphilis. So we continue to have progress in different countries. For example, in India, HIV, syphilis, elimination of vertical transmission was started in 2023, piloted, and then was subsequently expanded all over the nation in 2025. And in 2026, the government established the National Validation Committee for Triple Elimination. Thailand and Sri Lanka are both working towards the hepatitis B elimination of mother-to-child transmission. And very importantly, that modeling estimates have shown Bhutan and Thailand having achieved the 2030 goals already of hepatitis B elimination. However, validation would be an important next step. In the region, AIDS is not over. SEAR is experiencing a stagnating epidemic in progress. We have better 95 cascades with the latest data out this year. However, we are challenged by having 2 out of 10 SEAR countries having treatment coverage less than 50%. Late diagnosis with low CD4 count continues to drive avoidable illnesses and death. And the SEAR region retains a large epidemic with expanding epidemics in 4 countries. Nearly a quarter of people living with HIV are still not receiving life-saving treatment. So over here, you can see in this table that Thailand is on track, but the rest of the other countries have progressed, but not quite yet on track. And very importantly, every hour, 3 young people are getting infected. These are young people between more than 15 years to less than 25 years old. And these are the future generations that are still getting infected with HIV. HIV prevention is still at a critical inflection point. Key populations are not reached with effective and adequate prevention services, including pre-exposure prophylaxis. And over here in this first graph, showing different countries in the Asia-Pacific region, we bear lessons learned from Fiji and Philippines, which are seeing substantial new HIV infections. So, but we have also in PrEP coverage a relative 98% gap in 2025. However, there is optimism in the region because by 2027, there are potential game-changing HIV PrEP long-acting injectables that cost $40 per person per year, which are Indian generics which are slated to come into market. Heading on to hepatitis elimination by 2030, because this week we celebrate the World Hepatitis Day, 28th July. So in hepatitis elimination, the region is not on track. There is uneven progress across the region. Some countries are faring better, but some countries still have yet to initiate, to establish, and to consolidate gains. Overall, hepatitis B birth dose is less than 90%, although over here you can see that the pentavalent is pretty good. There are 6 countries that have been verified for hepatitis B control through vaccination of less than 1% hepatitis B surface antigen, seroprevalence among children over 5 years of age. And we can see also that we fare not well in testing and treatment of people living with hepatitis B and C. Although Seattle does have one of the lowest benchmark pricing for both hepatitis B, tenofovir, and entecavir, as well as the hepatitis C DAA drugs. Liver cirrhosis and cancer are projected to increase due to hepatitis B and C beyond 2030. And overall, because we have very inadequate surveillance systems around hepatitis, there is inadequate data on the cascades coverage of hepatitis B, prevention of mother-to-child transmission during pregnancy, and also a concurrent issue of hepatitis C infection in pregnancy, especially in humanitarian and in fragile settings. So in turning on to sexually transmitted infections, there are challenges and opportunities. I would like to remind everyone that there are more than 30 different bacteria, viruses, and parasites known to be transmitted through sexual contact, including vaginal, anal, and oral sex. So we know of the usual STI causing pathogens, but very importantly, Mpox is endemic in several countries now, as well as there is a Zika virus that also is passed through sexual contact and causes microcephaly based on data from several countries. And over here, you can see the table for coverage of syphilis testing in pregnant women, where we have the most data in syphilis in pregnant women and congenital syphilis. So there is a high burden and an opportunity to improve services for STIs. But what we're required to do is to strengthen STI surveillance, improve STI drug resistance, especially gonorrhea drug resistance. And we are very concerned around syphilis increase reported in several countries, and especially among young people less than 25 years of age. But the overall messaging around STI is that elimination of congenital syphilis by 2030 is feasible And it can be done through triple elimination and improving the maternal child health services. I would like to call everyone to a call to action, because elimination in the next 54 months is possible. Elimination as a public health threat means combining all existing interventions at scale. And that's where we really talk about coverage. So it spans from hepatitis B immunization to specific intervention for prevention of mother-to-child transmission, for HIV, for syphilis, hepatitis B and C, treatment, to accelerating the adoption of quality assured diagnostics and multiplex tests, which are also going to come into market. We have to improve the choices for HIV prevention through PrEP, both oral and injectable. And we have an exciting tools that are coming in the next several years. Very importantly, we have not to forget good harm reduction services for people who inject drugs. And this is the area that is often lagging behind in most countries in the region. So coming to TB, we know what is working. We know that it's persistent challenges. We have a lot of the tools. We have the expertise. We have AI and digital health, and most importantly, delivery and engagement and provision of services by communities, effective communities. And this is what works. But really importantly for TB is, what can we do more? We can accelerate, we can improve, we can expand active case finding, prevent through TPT, and diversify the groups, embed in convergence and integration of service delivery, and most important, to reinforce multi-sectoral governance and public-private partnerships. And very importantly in this region is begin vaccine preparedness, because it is coming. So for the region, what is important is adapting to the new funding environment. We have a long list of things to do, but the good thing is that we have the tools, we have expertise, we have the experience of elimination, and we have collaboration and partnerships, including looping in public-private partnership and very successful, highly effective community-led services. So we know all these things well. And how can we move forward? We should also, in this new funding environment, when we ask to say do more with less, I say we can do more with doing differently. And what is that differently? It is optimizing partnerships, leveraging each other's strength and investments, and together moving forward. Thank you.
Hello.
Yes, thank you so much, Dr. Po-Lin Chan. I think it's a very important opening statement here, and your keynote really draw home the message that why are we still not on track onto NTB, despite as well as hepatitis, STIs, elimination of vertical transmission, or for that matter, so many other co-infections and comorbidities. It is a very important reminder, and thanks a lot for setting the stage. So, without any further ado, I will. Is Pankaj Bhai, is Shibu there, or should we move to the next speaker?
No, sequence not here.
All right. Okay, fine. So we can move to now. Let us go to the keynote address by Dr. Tara Singh Bam. Dr. Tara Singh Bam is a senior person who all our life for over 2-3 decades we have known him, very passionately involved from Nepal to so many other countries like Indonesia and in the region of Asia Pacific, where he has been advancing public health. Dr. Tara Singh Bam his work speaks for himself. Like his work is a testimony that why local actions are important, why local coordinated actions are important. Coordination between TB program, HIV program, hepatitis program, funding, finance department, so many other government departments and ministries is very, very important at the local subnational level. And that is what determines whether we will deliver on global goal at local level. So Dr. Tara Singh Baum is currently serving as the board director of the Asia Pacific Cities Alliance for Health and Development, which is an alliance of mayors, members of parliament, subnational governments in several countries in the Asia Pacific region. He's also the director of tobacco control for the Asia Pacific region for vital strategies, and he has also served as the regional Asia Pacific Director for International Union Against Tuberculosis and Lung Disease for several years. So, and I would like to also credit that Dr. Tara Singh Baum is the person who inspired us by naming the campaign of Prevent, Find, and Treat TB to prevent, find, and treat all TB, because we have to prevent all TB. We have to find all TB. We have to treat all TB if we are to end TB. Thank you, Dr. Tara Singh Baum, for those insights. Pankaj Bhai, can you please kindly share the video?
Thank you so much for the conversation. And my special thanks from your lecture. Hello. Hello.
Yes, Jugan Bhai, we can hear you.
Yes. After Dr. Tara Singh, I share something.
Yes, sure.
Initiatives, the many different programs around the world have been significant progress in advancing diversity and millions of lives in. However, again, think about the moment when we experience that is why TB is one of the major killers in the world. For this, there are several reasons. Some of the reasons that I have tried to put here together based on my experience working on the ground and the various settings. So I would like to highlight some of the key reasons or it that we are not able to end tuberculosis and AIDS. Some of them are the root cause of TB are not being addressed. The health system remains more reactive rather than preventive. The screening strategy remains too limited in some of the settings, and it needs to be expanded to a larger scale at the population levels. As we know, the social and economic determinants also continue to fuel tuberculosis. There is always the issue of the universal health care. So the TB control programs around the world haven't been fully covered by the universal health care. Prevention program remains under-invested, such as tobacco control programs, the controls, and so on. Funding is another major issue that we all know, and whatever we are doing is not enough. We need to do more. Therefore, there are some other political reasons, that we are quite behind the ending tuberculosis. There is untapped local leadership and political will. In any country, a decentralized system, local leaders play a critical role to shape the public programs. Therefore, we see in many of the settings, local leadership hasn't been properly applied. All of it, and the risk factors that we know in tuberculosis and many other public health programs, including the NCD as well, is the tobacco use as one of the key risk factors, including the diabetes, undernutrition, alcohol use, and HIV infections. Collectively, all these determinants or the risk factors, can be attributes to the millions of tuberculosis in each year. In terms of the issue regarding the finance or the budget, the money that we need for programs, especially for tuberculosis and HIV programs, of course, there is the funding gap, and also the most of the programs they are totally rely on the either international funding or the local or domestic funding. What we could see, there are some the opportunities for the governments for the programs to really have identified or find out the local resources, and this resources could be the health taxes. Health taxes on tobacco, health taxes on alcohol and sugary drinks, and so on. If the governments increase the tax on all these products, the immediate benefit is that would also reduce the prevalence of the youth, for example, the tobacco smoke or alcohol use or the sugary drinks. So that would also contribute to generate the revenue at the domestic levels, and that the revenue that would be generated from the all harmful products would help to invest in TB elimination program or in primary health care program, including the universal health care. So it is very important the government is to really focus more on to increase the taxes on products. So as I mentioned earlier, local governments, the wills and their commitments really capitals for implementation and enforcement of any program at the local level or at the community. So as one of the key examples of the tuberculosis, the people at the local level, the leaders at the local level, they know and they have a good understanding about local problems and identify the local solutions and also engage the different stakeholders, including the media, civil society, and community groups. So it is important to really make the local government accountable for the implementation of the programs, for the innovative strategies of their mass screening, the initiative at the community level for TV or the public. Therefore, I would really encourage to everyone here to really work with the local governments and make them accountable for them. The last but not the least, the strategy that we have at the moment to move from the peaceful to and this should be the really one of the political agenda both at the national and the local level as well as the global levels. So ending TB requires real people-centered the approaches, prevention-oriented, and multi-sectoral. This is not about replacing the current efforts on diagnosis and treatment, but it is about making prevention the first line of defense. So only by preventing TB, finding every person with TB early, and treating everyone effectively can we achieve TB elimination. So achieving this goal requires strong political leadership and strong engagement of the local leaders and strong engagement of the community and everyone. With this, I would like to thank to the organizer for inviting me to participate, for this very, very important session. I wish you all the best. Thank you.
Thank you, Dr. Tarak Singh Bam. There's no doubt about it that we can do so much better. And thank you so much for connecting the dots. And this is a big message for especially those working on a range of health issues and development. So I think Jogendra Upadhyay ji will like to say something. Mr. Jogendra Upadhyay is the project director at Gujarat AIDS Awareness and Prevention Unit, ISRCDE. Jogendra bhai, are you there?
Okay, I am.
Oh, please,
Yes,
be welcome. Please be welcome to share your insight.
Our national AIDS control program, NATO, have adopted 3 pillars. It's Salamat, Suraksha, and overall Suraksha. One is the regarding to the 95, 95, 95, and our India NACO adopted 95, 95, and 99, and more four pillars of the safety of the each and every key population, and also including the PLHI. First is the HIV testing the all the key population for the screening of HIV, and also index testing, and all the key population testing for the syphilis, and if we the syphilis positive detected, and refer to the STI clinic. Third is also important of the hepatitis B and C. And hepatitis B and C, if positive detected, so refer to the civil hospital for the treatment as per the viral load. And third is the TB of the all the key population and PLHI. First is the forest screening, and also screening by also some detect some circumstances like alcohol using smoking, have a past exposure history of the TB, has a family history of the TB, and working on the cement factory, mines, and so many. All the factors, they were for the doubtful cases, and also refer to the chest X-ray screening. If the TB detected in the case of doubtful cases, to collect the sputum, morning sputum, and refer to the dot if the positive detected. Here is the four pillars of the testing and screening. Is a very good for the prevention of the all the suspects of the HIV, TB, and hepatitis and tuberculosis. This project in the 90, 95, if the HIV positive detected in the testing of the spouse and sexual partner and family members, is a core activity of the every NGO for the detection for the index testing. If the index testing in the index testing positive detected and linked with the ART center. This this program have a one key activity is the LFU tracking, because the LFU tracking and misdoses and also opted out cases are for the risk of the spreading HIV and also syphilis and also STI. Therefore, each and every LFC cases and opted out cases is rejoining for the ART center. This is a good, but we have a lacking something. Further, this program is focused on the key populations like FSW, MSM, and some migrant, some truckers. But a lot of unserved people like in informal sector are forgotten. Second thing is we have an opportunity of the PrEP. PrEP is one of the options of the prevention of HIV. And here is the let so many few NGO and so many few institutes are working in the PrEP. All in mostly the NGO working on the targeted intervention program. If they are not involved in the PrEP, the and also the at the risk population, like discordant couple. One partner is positive and the spouse is negative. That is under the at the risk population. There are the needs of the PrEP because the use of condom regularly sometimes is the for the young people are the very hurdle and barrier. Because that some is our culture. After young people wants to the child and all these things. If the PrEP use and if the PrEP is a uh, well wisher to the also prevent the HIV and also he fulfill his family. Thank you very much. Bye.
Thank you so much, Jogen bhai. Bilkul, you're very right. In in bringing in the context of those we seldom talk about, and those are the most important populations when it comes to TB, but also when it comes to HIV and so many other issues which you have just rightly pointed out. We really need to, if we are to deliver, like you come from Gujarat, and Gujarat Gandhi ji also used to say that, when we use, if we want to serve the poor, we need to think of design programs for the poorest of the poor. So not no and this is but we do the other way around. So I think we really need to make sure that our programs and services are reaching for hepatitis, sexually transmitted infections, TB, HIV, you pointed out syphilis and others, in to the most underserved populations. So thank you so much for championing good work at GAP. So moving forward, so now let us move forward and dive deeper into the session. We have a very brilliant example from, we have heard a lot of challenges, right? But in this session, this is the only session at 26th International AIDS Conference, AIDS 2026, which is presenting a successful example of the only geography, only part of the world which has become TB free, and that is Lakshadweep, which is one of the states or union territory in India. It is the only part in the whole of world which is TB free. So, Jogen Bhai, sorry, Pankaj Patel from Gujarat. He's a project director at Gujarat AIDS Awareness and Prevention Unit. As I've told, he is there on site at AIDS 2026. He will help us show the presentation of Dr. Rakesh PS, who is a TB elimination expert and who will tell us the journey of Lakshadweep from going to zero or TB elimination levels, at least bringing down TB elimination levels in real life settings and program settings, uh, 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 in India, which is the highest TB burden country in the world. But it is doable, it is manageable, and and this is how we can do it at the government level, as and of course with the cooperation of communities and everyone. Over to you, Pankaj. Thank you.
हाँ मिल जाओ तो हाँ भरतुआ तो है तो मुझे बोला था
Every community has a story. Every story begins with people. This conversation begins with one.
And here, the story of India's first TB-free geography echoes from the atoll, not as an expert, but as an author. For those of you who don't know about Lakshadweep Islands, they are a group of 10 tiny human-inhabited islands. Southeast coast of India. Because of the geographic dispersion, heavy dependence on the United transport, the inter-island connectivity always remained uncertain. In a typical year, for almost 5 months, the monsoon-related disruptions made it so difficult even to reach the supplies to these islands. There used to be one gene expert machine in the headquarter island, but since the sputum samples need to cross the vast Arabian Sea, its access remains limited in terms of diagnosis and treatment. In 2019, based on the Government of India's call to end tuberculosis, the Lakshadweep administration brought out a strategy document. It is a contextualized, customized version of Government of India's national strategy plan. The entire island administration was there to witness the release of the documents in the presence of the entire island community. This is a landmark day when all the community volunteers from the 10 islands, they kept their hands on their chest and pledged to make their own islands TB-free. From that day onwards, it literally became a people's movement against tuberculosis. Each of the islands, they form a TB elimination task force. Officials, local government representatives, religious leaders, representatives from the women's self-help group, youth club, people with lived experiences. This task force planned, endorsed, troubleshoot, ensured equity, inclusiveness in coverage, and mobilized resources and reviewed the activities in their concerned islands. At the same time, the health system mobilized additional molecular testing machines to each of the islands. So now every island could perform molecular tests with their own hands. That decentralization brought testing closer, the diagnosis closer to the people. The community volunteers, they went from house to house to search for TB cases. And they did it for 7 consecutive years. Island task forces acted as treatment support groups and ensured successful completion of it. Look at the coverage, it's more than 75% each of these active was finding around. And the number of cases came down year on year. And in 2024, it was finally less than 20 per 100,000. The incidence was less than 20 per 100,000, whereas the actual incidence in India is 200 per 100,000. 2021, Government of India, WHO India, and ICANN, based on its national certification, has certified Lakshadweep as the first TB-free geography in India. Yes, the son of a TB-free India arose in the West. The key takeaways are bringing services closer to people is essential. Diseases are eliminated when communities become the real owners. Simple interventions delivered consistently one, and TB elimination is possible. I have documented the entire human story behind India's first TB-free geography. My book, Echoes from the Atoll, which has been released globally yesterday by the Stop TB Partnership Executive Director, Vijayan.
Yeah, thank you so much, Dr. Rakesh. This is a big hope. Thank you and congratulations for the release of the book yesterday by the Executive Director of the Stop TB Partnership in Geneva, Dr. Luchika. This is apart from that, like this gives me so much of hope. It is doable to end TB in the one of the in not one of the in the highest TB burden country. So in India, we could do this in one of the states or union territories as we call it. But this is very very important, and also it brings out the importance of taking services to the people, which Gujarat AIDS Awareness and Prevention Unit team has been doing it for migrants and other populations of unorganized sector. So taking services closer to the people, closer to the communities, it's so important. And this is exactly what you fundamentally was a big difference in Lakshadweep when and thanks a lot for explaining the geography of Lakshadweep. It's so important. Thank you, Dr. Rakesh PS. So again, so now let us move forward. Sorry for taking so much of your time. Can we listen to Jahangir Alam, Pankaj Bhai, who is a TB survivor and also works as National Partnership Officer with Humana People to People India. Humana has worked for years with homeless people, unhoused persons, migrant workers in several parts of the country, but especially which I have personally witnessed and spoken to several people with TB or HIV and or both in are in Delhi, including sex workers and others. So over to you, Pankaj Bhai. Let us hear to Jahangir. Yeah. Thank you. There was some audio issue, so I was not able to hear fully. But this is a very important presentation, friends, in this 26th International AIDS Conference. The only presentation in the whole of conference where government programs were brought together, where people live who come at the ART center, government run ART center in Delhi. They were screened using AI enabled x-rays from the TB program with help with frontline workers of Humana People to People India, and they could find TB early. Over 50% of TB was asymptomatic, no symptom, but they had TB disease. They could find it early and early. Why it is important to find early? As Jahangir rightly says, that if we find TB early, then we can stop the spread of infection, reduce the damage TB bacteria will do to that person, and put that person on the healing, treatment, care, and support journey. So very, very important presentation about synergy of between TB and HIV program, but also that TB program in India is already using AI enabled X-ray for screening people for TB. But uh, HIV program is asking symptom only. It's only symptom only screening. So I think that is a very important science-based, evidence-based transition that needs to happen. HIV program also needs to use AI-enabled X-rays to screen people for when they come for ART into collection, etc. For TB and their contacts and likewise. So thank you, Jahangir. Thank you. And now the AI which Jahangir, which these government X-ray machines are using is called Genki, and Genki is of Deep Tech, which is a India company in Pune called Deep Tech. So Dr. Amit Kharat, he is the CEO and co-founder of Deep Tech AI. He is amongst us virtually. And Pankaj Bhai, please let us know what Dr. Amit Kharat has to say for his when we talk of artificial intelligence, we think it is about rocket science, it is about big things, it's about AI. But here, Dr. Amit Kharat's Deep Tech Genkai AI is being used to serve the find TB among the most underserved populations, among homeless, among migrants, among high-risk key populations, and of course, also at the ART centers in Delhi. Over to you, Pankaj Bhai, for another Made in India presentation.
Thank you for inviting me for this presentation. In the next 5 minutes, which I'm going to cover, now the more important was in my topic will be finding people with TB. I think that's the most important one because that's where we are losing pace or losing ground. And hence, if anyone who would like to realistically achieve the target of ending tuberculosis and AIDS, both and epidemics together, then we have 15 more months left to do that. And if we can pick up pace in finding more people quickly using the existing tools, we should be able to meet our targets and goals. We're not failing at finding at treatment. We're not failing at treatment. We're basically failing at finding. And TB is the leading cause of death amongst people living with HIV. Around half of the people in the community with bacteriological confirmed tuberculosis report no symptoms like they are screened. As of it, symptoms is not going on. They are going on this many tuberculosis cases. Unfortunately, we don't have a chest X-ray to this. Treatment will save lives, and it is saving lives, but it can only help once we identify the people having tuberculosis. Chest X-ray finds these reading is where the bottleneck is. So if you see, WHO recommends chest X-ray alongside the core symptoms for people who are living with HIV. It raises the sensitivity of screening and helps rule out tuberculosis before starting the preventive therapy. For people on antiretroviral therapy, we want a sensitive screening strategy. But what held it back is that every chest X-ray needs to be read by an expert. Unfortunately, in most high-volume settings, there is no radiologist available to support HIV clinics. Images wait for days to weeks to get reported, and sometimes not even reported at all. And even when they are reported, there will be times and moments where the readers will disagree most often than they would like to admit. And for decades, the limiting factor for TB screening has not been the chest X-ray, but the availability of an expert to treat them. However, this has changed with the availability of CAD products, computer-aided detection tools, which can screen a chest X-ray for tuberculosis and multiple other lung conditions within less than 30 seconds, completely offline. The policy barrier has already come down for using these CAD products. In June 2025, WHO recommended and endorsed 6 CAD products that met the target performance profile. TB performance standard set for TB screening. CAD removes the need for an on-site reader, one of the biggest hurdle for tuberculosis screening. It eliminates the inter-reader variability and it delivers the results within seconds at the point of care. Literally, by the time the patient changes their clothes, the results should be available. As in the positive CAD result indicates the need for a confirmatory test before treatment. So once the CAD is used, we basically use it as a screening tool and not a diagnostic tool. And since 2021, WHO has recommended these computer-aided detection AI reading of the chest X-ray as an alternative to the British for TB screening and triage. The recommendation covers all adults aged 15 years and over and explicitly includes people living with HIV. So this is no longer a pilot question because in Tamil Nadu state alone in India, one of the most popular states, along with other states as well, AI-read chest X-ray started with the Greater Chennai Corporation, moved to 4 districts, then to 6 districts. Now 15 districts are covered, and more than 2 million people have been screened using this. Tamil Nadu should be 500,000 people from 2019, out of which 56,000 individuals were studied for a period of 1 year, part of this cohort. Then it has been even to be demonstrated like a 2-fold increase in TB diagnosis compared to the standard pathway. Almost same number of people, the same program, but a different way of finding them. A 60% reduction in cost per poly. Cost effectiveness threshold CET lower by 92% with AI interventions, indicating that AI interventions are highly cost effective. This is published as a research paper as the AI-CAD enhances permanent TB detection and period in active case management, and this covers the entire study. These are the bands from which the screening is done, and this is how the operator handles the laptops on which the AI results are available after the patient has been X-rayed. This is not limited to Tamil Nadu alone. This is the global deployments are seen. So more than 2 million people screened as a part of the global deployments, where portable ultra-portable X-ray devices along with the AI, which is a CAD solution, has been deployed in more than 440+ sites across India, but this is not India, Africa, Southeast Asia, right up to Mongolia, every nation, including UK. Whether it is in public healthcare setting, where there is high transmission risk, where we have undiagnosed cases, where there is limited access to experts, in certain sections of the community, in business. There have been projects with Global Fund projects with Alliance India, and also projects with UCL in London, along with NHS UK. Now, the part which we do not say often, but it needs to be discussed, is that the computer-aided detection tools performance and accuracy in people living with HIV and those in prior to it definitely needs additional assistance. This is why threshold which has been calibrated locally and not inherited from vendors needs to be considered. And this is a solvable problem because only programs start adopting check X-ray with CAD solution. They can calibrate, they can learn from the experience, and now they can calibrate locally and share results. So, three forms available to us right now is where screen where people already listen to. To migrate the checks here, bring CAD into routine HIV clinical visits without waiting for radiologists to become available. Calibrate for the population, establish and publish the CAD threshold specifically for people living with HIV. Invest in the subgroup evaluation that remains scarce. Last one, but not the least, the most important, is close the pediatric gap. CAD is not yet recommended for children under 15 years of age. Children living with HIV remain among the most underserved population across the TB care pathway. None of these require new science. All this requires is action. We have 54 months left. Finding people with TB remains the slowest gap in the care cascade. Yet it is one step which effective when effective tools already been available with you well and at pace and using the current policy which is already supporting the use, we will be able to meet our targets. So finally, in conclusion, we already have the tools to fight TB. But then we need more people having the chance. What remains is the decision to be and to ensure that they will as well for people living with HIV and we do for everyone else. Thank you so much for your time. And if the last concluding message being if we are able to enhance the pace finding TB using this technology, I think we have done it. Thank you so much.
Thank you, Dr. Amit Kharat. This is very, very important presentation because especially because like I really was at very impressed to read that deep tech Genki AI can screen people for over 25 diseases or 25 pathologies, let us put it that way. So when a person takes a Genki AI X-ray, that scanning tells you about 25 or 27 pathologies. That is a lot. We are only looking at TB. So, but even that is so important in terms of public health impact. So I really hope that the information we are getting from AI linked is connected to public health workflows. People who are suspected for pneumonia, cardiomegaly, etc. They are also connected to relevant pathways. But thank you so much for this presentation. Friends, this is so important that we need to find TB early and accurately. Early and accurately. The only way we can find it early is we need to use AI-enabled X-rays as Government of India guidelines and also as WHO guidelines of 2021. If we use AI-enabled X-rays, we get to know who could be presumptive for TB, who may have TB. We need to do further tests, but we can screen people who are asymptomatic. Even Government of India, Nepal, so many other countries survey shows that almost half of the population of TB disease people may have asymptomatic TB. So we can find it only when we use X-ray. So this is very important. AI ka istemal se the most important thing is that we don't need a radiologist. The radiologists are so scarce. They are so difficult to. They're so busy in high burdens countries like India, for example. So AI is very, very important so that we don't need a radiologist. AI enabled X-ray can we can find people early and offer them molecular test upfront so that we can confirm if the suspicion of AI, whether they have TB or not, is correct or not. And if they have the disease, then they can be linked to the treatment. And among people living with HIV, TB is the deadliest of infection. So thank you so much for bringing this point out. And let us hope that no one needs to die of TB, because TB is preventable and curable. How many times you and I have heard this statement that TB is curable and preventable? But it is not preventable for almost 1 crore people every year in the world, because they get infected with TB. And it is not curable for almost 13 lakh people who die of TB every year. So we need to do some accountability, bring in some more accountability. We can do better. We know how to prevent TB. We know how to find TB. We know how to treat TB, but we need to do better. We really need to do better. It is time to save lives. No one needs to die of TB or HIV or hepatitis, because we can do better. We have the tools. We have the science with us. We have community-led interventions like a Gujarat AIDS Awareness and Prevention Unit, who have demonstrated the same level of efficacy. And for example, viral load suppression, for example, HIV testing, etc., as comparable to the even surpassing what is in general population. So community-led interventions are also extremely very critical to link the high-risk populations with public services. So with these words, Pankaj Bhai, will you like to have any closing remark? Over to you, Pankaj Patel.
Thank you very much for all on our online viewers and in-person viewers. So, may I Dr. Patel, Gujarat AIDS Service and Prevention Unit, Gujarat, India. So, all thanks for our presentation. And thank you very much. Thank you.
Thank you. Thank you. Goodbye. And all the best, Pankaj, for the remaining of AIDS 2026. Bye-bye.